I would speak very rapidly, but I think I could accomplish it. I could accomplish it. Well, thank you for that introduction, Dr. Sterling, and thank you, Larry Ivory, for convening this. Thank you to all of the distinguished panelists, and a special thank you to Senator Kaler. Let me start by saying, I'm going to start by kind of bringing the national trend in and then funneling that down to the state level, so you can see exactly where we're coming from and what I actually have identified in order for us to move forward. So I'll start by saying this. In 1970, the United States spent $67.3 billion on healthcare throughout in the entire country. That represented 6.9% of the gross domestic product. In the ensuing 40 years, and the most recent data that we have, our spend has now increased to $3.8 trillion, and that now represents 17.7% of the gross domestic product. That has a huge economic impact, not only in dollars that are now consumed by healthcare that could be spent on everything else, but that earlier in this decade, that showed no signs of abating. And so the United States and states themselves have both tried their very best to see how they could curtail that growth in healthcare. And so what has happened up until this point is that the United States, the governments, both national and state, have taken steps to try to curb the cost. But what it's really amounted to, in effect, is they've been haggling over the price. So you've never seen any changes, for example, in let's see how we could reduce hospitalization rates. Instead, what you had is you have argued over the price of hospitalization. And so what you saw were cost control measures that were taken, designed to provide the same hospitalization, but at a lower cost. And so you see things like HMOs, and you see things like MCOs that have sprouted up, which are designed primarily to reduce the cost of the service and not necessarily address the service itself. And so what you really have is a kind of a price haggling that was going on. In the state of Illinois, this has manifested itself in the creation of MCOs, which are really designed to cap the level of state spending. And what this has done is, of course, in the world of worst possible outcomes, the MCOs are given a bucket of money from the state, which they are told to spend to stay within the spending limits. The MCOs, in their desire to make it profitable, then decide that we're going to spend as little of this money as possible. And so they make it difficult for hospitals to get reimbursed. And it's a stretch to get reimbursed. The MCOs keep the money, and the hospitals are kind of stuck in the middle. And again, as Dr. Sterling mentioned, I was the CFO of Rosen Community Hospital, and I saw this firsthand, that in order to get money from the MCOs, you almost had to take a side route and go to some influential folks in the General Assembly to make sure that you could get the money that you were owed. But the bottom line was that we were really trying to get money for doing the exact same things that we have always done. And so that is kind of that's kind of the generic setup. Now, one of the things that drives a lot of the cost is that we have a great number of emergency room visits, and it was hoped that the Affordable Care Act would prevent or reduce the number of ER visits. Instead, a study actually showed that the number of ER visits went up by 5.7% after the Affordable Care Act was implemented. And further, if you break it down into groups, the number of ER visits from Medicaid patients actually went up by an astounding 41%. And what this means is that we simply were driving more people to the ER, and it was not functioning the way that it was intended. This same study also showed that only 11% of the ER visits resulted in hospitalization, which meant an astounding 89% of your ER visits did not result in hospitalization and resulted in people making a visit and going home. What that means in raw numbers, especially for Medicaid, is that you had 1 million visits, over 1 million visits that cost at a ER visit of 2,500, the ER cost of 2,500 per visit. These 1 million visits that resulted in no hospitalization cost Medicaid about $2.5 billion. In the state of Illinois, we actually spend $19 billion annually on Medicaid and related services. So that is a great deal of money, and to see that 2.5 billion of that is going towards essentially being checked up and sent home, that produces a cost inefficiency that needs to be addressed. And so with the spend that is going on right now, what we're now doing, what we see happening now is there is a trend towards outcomes-based care. And the hope is that outcomes-based care will produce better outcomes at the end and also save money by being more efficient. Now, what SIMPCO is doing now is we are looking not only at how do you reduce the hospitalizations and things of that nature, we're focusing on the preventive aspect of care. Preventive care is shown to cost a whole lot less, and it actually improves the qualitative outcomes for people who are participants. And so if you can catch something early, then that certainly gives us a better opportunity for treatment and a better outcome. And so SIMPCO is focused then on preventing and reaching out to folks before they have to go to the ER, and thereby saving and mitigating that cost. So the other aspect that is important, I believe, to the chamber is that you have $19 billion of healthcare spend. And certainly with the Affordable Care Act, we've reached out to communities of color and everything else to ensure that these folks are being treated properly. But the next question becomes, it's not only an issue of who are you spending the money on, it's who is the state spending the money with. And so that issue is not only brings up the healthcare aspect, but also the economic empowerment aspect. And what we found when doing the research is that, the state has set aside 20% or set a goal of 20% BEP spend, but that's only for the administrative portion of this $19 billion. So what that means is we have about $4 billion in administrative spend that isn't directly related to the healthcare service, but it's $4.2 billion. And the pot then is only 850 million, which represents the 20% of the administrative spend. And so what we're looking at—
I want you to slow down that math there, because you just said a lot. So you're saying that yes, there's 19 billion that's being spent, and 80% of that amount is being exempted off the top.
That is correct.
And that leaves an administrative potential pool from which 20% of that money is set as a goal. So it's 20% of 20%.
Yes, that is absolutely correct.
For minority participation. Okay.
Yes. So what we're looking at is we're not getting a piece of the pie, we're getting a piece of a piece. And so that 20% again is a goal and not a mandate. So when it comes to the actual amount that's being spent, that actually comes out to $129 million, which is less than it's less than the amount, certainly less than the 850, but less than 1% of the 19 billion that is being spent. And so one of the areas of focus is how do we then increase that? Because, our belief is that we should not be limited to just a small portion or corralled into a small portion, but that we should be looking at the entire 19 billion as a possibility. That doesn't mean we should get all 19 billion, but what it says is that we should have access to all of it. And if we only get 5 or 10% of that, that's because we went out for it and bid fairly and so on and so forth. So our goal here then is to expand this pie and make sure that people like the chamber members and other related folks can get a piece of it. And so what SIMPCO is doing as part of our program is we are looking to ensure that we hit at least 30% BEP spend at SIMPCO, and we are reaching out to Black and minority businesses throughout the state to ensure that they can get a piece of this pie. What some of the interesting figures that we can talk about economically is that Black businesses receive on average about $54,000 to $55,000 in annual revenue. So that's not net profit. That's how much they receive in annual revenue. And so from that $54,000 to $55,000 in annual revenue they have to now, spend on expenses and everything else. And that certainly does not leave room for hiring employees, for business expansion and things like that. SIMPCO is actually thinking in a much larger vein, and we're looking to have Black businesses participate at a level where they can now become self-sustaining and even grow. So our goal here is to make sure that the Black businesses that work with SIMPCO, minority businesses that work with SIMPCO, will get enough to expand their own businesses independent of what they're doing with us, but that we can become a major driver in the economic improvement of minority people and minority participation. And so our goal is not only improving the healthcare outcomes, which I believe is extremely important, but also in ensuring that there is economic empowerment and that there is a benefit as well.